Right. So I want to take a moment to thank everybody for joining us today. Today is August the 3rd. For those of you who are registering for CME credit, please note the activity code that's listed there. Make sure that you do register before midnight tonight. I'll go over some additional information here in the next slide. So if we can go to the next slide. For those of you who have not yet registered, you'll need to make sure that you do text your email address to the toll-free number listed there. Once you've done that, from that point forward, you just need to text the word attend and then the activity code for today, which is listed there for you, to that same toll-free number. But if you're having any issues or any questions, please feel free to reach out to me. Again, do make sure you do that before midnight tonight. Next slide. So we're going to go ahead and get started here. Just a reminder, if you could please make sure that you do have your microphone muted as we get started. Also, if you can be engaged and attentive to the session and the presenters. Towards the end of the session, I will be putting in the link so we can provide feedback. But also, if you have any questions, please use that chat box as well. We'll be taking a look there for any questions that you may have. Next slide. And just to let you all know, we are partnered with the South Central AHEC. Our department's mission statement is also listed there for you. Next slide. For those who are claiming CME, you will want to make sure that you check your CME transcript every so often. You can do that by logging into the CME office website as shown there. But if you're having any questions, please feel free to reach out to them, or you can reach out to myself as well. Next slide. Also, those who are members of the AAFP, don't forget that you can also claim credit through their system. Their information is listed there, so please feel free to reach out to them or myself as well. Next slide. We do also want to mention that it is our goal of these sessions to make sure that we address the nationally established physician core competencies that you see listed here. Next slide. And then finally, we want to mention that Maria Hernandez and Joanna Garza, neither one of them have financial relationships with ineligible companies to disclose. Next slide. So they are going to be discussing for us today primary care behavioral health at the border. So I'm going to let them go ahead and get started.
Good afternoon, everyone. So our title presentation is Primary Care Behavioral Health at the Border, Workforce Development at UTRGV School of Medicine. My name is Maria Hernandez, and I do go by Lupita. I've been in my role as Director of Special Programs for the Department of Family Medicine, integrating behavioral health for almost 7 years. Before this, I worked at UT Health Science Center San Antonio and UT Austin, working in student pipeline programs. In the past 7 years, I've immediately grown passionate about change that our team has brought to our community and continues to bring to our community of the Rio Grande Valley. And this is through IBH and workforce development and other areas that I'll discuss later in this program. Joanna?
Hi, everybody. My name is Joanna Garza. I'm a licensed clinical social worker by trade, but I am a behavioral health consultant. So I was very fortunate in my graduate studies at the University of Denver to get a stipend that focused on integrated behavioral health. And so that was my first introduction to integrated behavioral health. I did my internship at a family residency program in Colorado, St. Mary's Family Residency. And from there, I just really grew to be passionate and love the work of primary care behavioral health. And I've been here at my role as a behavioral health consultant at the DHR Family Medicine Residency Program since January 2020.
And Joanna is from the Rio Grande Valley area too, so.
Yes, born and raised. I left for a few years and came back, and I'm glad to be able to do the work that I love in the community that I grew up in. So some of our objectives here We really just want to help define the primary care and the primary care behavioral health model. We want to outline the development of primary care behavioral health services here at UTRGV, and especially our family medicine residency programs. We want to summarize the expansion of primary care behavioral health related projects that our team has been in charge of and expanded since early times that they started, and then describe resident education and its relation to PCBH work here at the residency that I'm located at. So defining primary care, I'm sure each of you is familiar with the definition, but just a refresher. So defining primary care as high quality primary care is a provision of whole person, integrated, accessible, equitable health care by interprofessional teams that are accountable for addressing the majority of individuals' health and wellness needs across settings through sustainable relationships with families, patients, and communities. And this, as most of you guys know, or hopefully did know or will learn, this definition was updated in May 2021. And so just a couple of different models. The one that we will be focusing on is the primary care behavioral health model. That is the model that we practice here at the DHR Family Medicine Residency that I'm located at. So primary care behavioral health is defined as team-based primary care approach to managing behavioral health problems and biopsychosocially influenced health conditions. The main goal of this model is to enhance the primary care team's ability to treat such problems and conditions, resulting in improving the primary care services for the entire clinic population as a whole, not just the patients that we serve, but the physicians that we work with and the populations that we're located at. So these clinics are equipped with a behavioral health consultant like myself. And so just briefly going over the model. So the behavioral health consultant extends and supports the primary care team. The BHC works as a generalist, just like a family physician, family medicine physician. We're generalists. We work with anything that you guys see, we see as well. We also work as educators. We want to continue to educate the population, the patients that we work with, physicians that we work with. We also provide high volume services. So for us, we really focus on trying to see as many patients as we can in a half day. So we might see upwards of on the low end, 5 to 7 or 8 patients per half day. We are accessible, so we want to be accessible to the team at any point, whether we're in the room with the patient, seeing somebody, you can come in, interrupt us, and we can take any warm handoffs. Team-based, so we're part of the team and hopefully being used as a routine part of services for any and all the patients that are being seen in the clinic. And so let me just get this pulled up. So primary care behavioral health, just a couple things to kind of keep in mind. The stress-linked physical symptoms and maybe even preventative lifestyle things on the left-hand side are things that you would typically maybe even see as a chief complaint in a typical day. You might see somebody coming in for headaches or irritable bowel syndrome, or maybe obesity, sleep concerns, or any somatic issues. We might also be focusing on chronic disease management like diabetes, hypertension, obesity, depression, anxiety. Or patients might even mention things during a visit with you, like they're experiencing marital conflicts, or end of life care might be coming up for their caregiver or a patient. And then on a daily basis, we're talking to patients about wanting to change habits, wanting to improve behavior, monitor behaviors, change lifestyles, improve health habits. And all of these things are not mental health focused, but these are all things that a behavioral health consultant or BHC can help in a clinic with. So just to kind of have this in the back of a mind, that these are things that any of these things on here are points where a BHC can touch on with a patient.
So this is our navigation slide, and it'll take us through our presentation, and it'll take us through a history of our work in PCBH and workforce development. Next slide. So this is our team. We have the PCBH admin team, administrative team, which includes myself as Director of Special Programs. We have Evan Garcia, we have Miss Myrna Ruiz, Salvador Arellano, Peter Averack, and all of us cumulatively work on project management, administration, research, budget, finance, compliance, PCBH implementation, quality improvement, and grant writing. Then we have our clinical team. We have Dr. Deepu George, who was our Director of Integrated Health Services at UTRGV. He's also a faculty at the DHR Family Medicine Residency Program, where Joanna's at. We have Dr. Varon, who is also a faculty at the McAllen Family Medicine Residency Program. We have Miss Joanna, who introduced herself, and she is our BHC at the DHR program. And then we have Dr. Cynthia Garza, who is our clinician at our Harlingen Multi-Specialty Clinic. And she is also our PCBH liaison for psychiatry residency program. Next slide. So our program really started with initial seed monies. And this was through a project called the See Texas Project, Social Innovation for a Healthy South Texas. And this partnership was collaborative with the Social Innovation Fund, which is a federally funded program, Methodist Healthcare Ministries in San Antonio, which you should be familiar with, and a local funder, which is the Valley Baptist Legacy Foundation. Over the 4 years, we got approved funding of over $5.6 million. And this is basically what allowed us to create the space to bring this new model of care to the Rio Grande Valley. Next slide. Through this funding, we were able to implement the PCBH model that Joanna defined and started clinics at 2 clinics, the DHR Family Medicine Residency Program and the McAllen Family Medicine Residency Program. Those were the very first 2 clinics where we integrated, and we were so blessed to say that we were able to bring Dr. Kurt Strassel and Dr. Patty Robinson to help train us as a team and each one of the residents and faculty and staff at each one of those clinics. Through time, we were also able to bring other great leaders of the PCBH world, but with this work and this very initial stage, we were able to bring them and have us be trained by them. Next slide. That project brought impact, like I said, over that 4 years of over 3,000 individual patients who received PCBH specific services, over 100 doctors who were trained. And over time as well, we added OB-GYN residency program to our list. So you will see there that OB-GYN is also included. And over 60 medical staff, right? So that means clinic administrators, leadership, front office specialists, lab staff, everyone was included who were a part of each one of those clinics. And something that I didn't mention was that each one of those clinics that we have, or those programs that we have, are affiliated with 2 separate clinical entities, private clinical entities. So that was a huge hurdle and a challenge for us. But thankfully, we were able to, kind of overcome and continue the work. Next slide. So this slide will just kind of show you the work over the 4 years of that initial funding and the impact we were able to make on our community. So the study, we were able to enroll 364 participants in our study and have a comparison site, and you can see there the number of total participants. And you can also see on the left-hand sheet at the bottom the results of our study. where it shows that our model, or the model that we use to implement, is significantly associated with PHQ-9 improvements in the participants. So again, small but great strides for our community in the Virgen Valley. Next slide. So we were able to continue our work after the grant through our Valley Baptist Legacy Foundation partner. Again, blessed to have a partner that believed in the work we were doing and the impact we're making. So we were able to continue to provide PCBH consultation services and experiences to our family medicine residents. Joanna will go into depth about that. We were also able to extend through the hiring of Dr. Cynthia Garza. Not only we were able to expand services to the Cameron County area, but we were also able to expand PCBH, kind of curriculum and into the psychiatry residency program through her as a liaison. We were able to continuously improve our level of assessment for each of the clinics that we were in, which again was DHR, we were at McAllen, we were at OB at the time. So again, we were just trying to continuously improve through assessments and quality improvement projects as well. We completed the development of 3 courses for master level students. We also completed over 16 workshops and lectures, and as well as we were able to help one of our BHCs advance to assistant professor to one of our other McAllen clinics. Next slide. So again, the ground level work with C-Texas project was monumental for us. This allowed us to get experience and be able to write for some funding. So that our first grant that we wrote for was for HRSA, and we were awarded a $2 million fund that spans from 2019 to 2024. So we're almost towards our latter part of this grant, but for this specific grant, we're focused on longitudinal education, research, trainee wellness programs, PCBH implementation and continuation and expansion, MAT waiver training, and working towards approving a PCBH certificate. Also, we're working towards asynchronous online modules for PCBH practitioners. Next slide.
Okay. Oh, sorry, Lupita, go ahead.
No.
Okay. So we're gonna transition and start talking about focus on the residency training here at the DHR Family Medicine Residency Clinic that myself and Dr. George are at, and really just the efforts that we've gone through to expand PCBH education and knowledge for the residents. So just a little background on our clinic. So we have 2 BHCs and 1 PharmD located at our clinic. We provide PCBH services and teach residents during their didactic lectures. And then residents work with us, the BHCs, all 3 years of their education. And then during their education, which we'll talk a little bit, get into in a little bit, the residents actually function in the role of BHC. So for PGY1s, the length of the rotation is 1 month. They work a whole month with us sometime throughout their first year. The goals and objectives for this month are really to understand the foundations of primary care behavioral health and common behavioral interventions in primary care. Topics that they learn and we discuss are ACEs, non-pharmacological treatments for insomnia, behavior activation, and cultural humility. We also have residents during this time complete the MAT waiver, the 8-hour training for that. and communicate. And there's also a community addiction rotation part of this, where they work with one of our community organizations on learning, kind of attending and learning a little bit about some of the services they provide. And then there will also be a scholarly activity where the residents are able to present to that community population. And then one thing that I forgot to mention with the PGY1s is that there's actually, they will do a pharmacy tour with our PharmD. Maybe it's in this slide, sorry. And then this is the remaining part, sorry, I apologize. So the breakdown is they engage in the role of a BHC. So they will run consults as if they were a behavioral health consultant, about 5 to 6 half days per week with guidance from myself and Dr. George. They really start with observations, scribing, getting to know the template. Then they'll work to running consults on their own, following the precepting model, very similar to their family medicine training. The remaining weekly breakdown, they have 2 to 3 half days that are dedicated to self-directed learning, where they're focusing on watching videos, reading articles, or anything else needed to kind of help enhance their learning on the topics that I mentioned, the overarching goals for the month. They still have their 1 half day of continuity clinic, and then there's a community the community rotation experience with our addiction clinic. And then they'll have 1 half day sometime during their month where they will do a pharmacy tour with the PharmD, where they will get to go to a clinic. They'll kind of learn the back end of what happens after we submit a prescription. They'll get to know a little bit about more of that process, what that looks like, and a little bit about the laws and regulations, or alongside our PharmD and the pharmacist at that local pharmacy that they will go to. And they do this with the pharmacist and up to three residents from our residency. For our PGY2s, they have a longitudinal rotation. This is throughout their whole second year. The longitudinal rotation has journal articles assigned every month. These articles are PCBH focused. They are focused on implementations for family medicine related to PCBH topics. They can use these articles for their journal club if they wish. Residents will have discussions with myself or Dr. George throughout the month, just thinking about the things that they learned and how that might be changed their implications, or how that can be implicated into their work with patients. They also have 2 half days every month where they are functioning as a BHC, and they will actually be able to schedule their own patients into their patient panel and work directly with myself or Dr. George, observing them so that they can kind of create their own BHC panel. There's also pharmacy co-visits. These are co-visits that they could do with the pharmacist during their BHC half day, so they could either schedule their own patients for this, or just as they're kind of going through the schedule for the day, if they're seeing any patients with polypharmacy, maybe new diagnosis, freeze, I forgot to mention that. Currently, we work with Westbrook clinics, and then we're hoping to continue to expand those. We had to pause those because of COVID, so we're currently building that bank back up. But that one day that they're assigned to, or that 1 half day they're assigned to BHC, if they're not in clinic, they're doing external rotations. They have PGY3s have a 2-week behavioral selective. This is all based on resident interest, and we help them come up with the objectives and collaborate what their 2 weeks would look like. So things that we've had in the past, we had a resident who was really interested in obesity medicine, so they really learned kind of behavioral medicine, and then we had another patient who was interested on being a hospitalist, so he did a lot of research and did BHC with the inpatient team. Other residents have gone on and worked with psychiatrists to learn more about bipolar treatments in outpatient settings, or how do we enhance depression or ADHD, outpatient treatments. And so really it's whatever the interest of the resident is, we just kind of help work with them to create that behavioral selective creating the learning objectives for them. And then again, the main objective is to help them understand the foundations of PCBH and continue to implement and build on those behavioral interventions. And they go through the same biannual evaluation that's linked to the family medicine milestones. Additional resident education opportunities. So there is 2 PCBH focused didactic lectures every month. One that is led by myself, Dr. George, or guest lectures. The second one is in collaboration with our PharmD. And so that lecture is really focused on going over the ADA standards, and there's an illness experience tied to that. And that's once a month, and the residents are working on those prescriptions or objectives for the whole month. We also assist residents with case complexity presentations that are held every month, helping them kind of present that and work through some of the requirements for that. And then we also do monthly narrative medicine sessions with each of the classes. So next steps in residency training, because of COVID and changes with schedule, the farm components were actually paused for the past year and a half or so. So this year we reintegrated the farm components. So we're just going to continue to monitor and make changes as needed, so we can kind of get it to where it used to be, and maybe even expanding from where it used to be. We want to look into adding additional sites for the longitudinal rotation. Currently, like I mentioned, we have our partner at Westbrook Clinic, which focuses on HIV treatment, but we're wanting to maybe expand that, adding psychiatry component as part of a longitudinal education as well. We want to continue to expand the evaluation process that we do for the residents, and continue to link those to the family medicine milestones. And then Fortify Resilience Grant, which is increasing, or we were recent recipients of a Fortify Resilience Grant, which was focused on increasing physician wellness.
Thank you, Joanna. So that wraps up our first HRSA grant with the expansion and development of family medicine curriculum. So our second grant that we received was the Integrated Interprofessional Primary Behavioral Health grant. And that was, again, another HRSA funding mechanism, and that was almost $2 million, grant timeline being July 2020 through 2025. And so for this funding mechanism, next slide, was to expand our initial plans and development through our previous grant for the PCBH certificate, right? So this one will and does focus on training graduate level mental health trainees in integrated behavioral health competencies to expand primary care ready BHCs in the community. Multidisciplinary graduate certificate, and 2 PCBH focused courses. And the PCBH focused internship within UTRGV clinics is what we currently we're working on. Joanna?
Yes. And then that last piece, we are actually expanding kind of clinics outside of the UTRGV clinics, just to kind of help. There's a few clinics in the area that are already doing great PCBH work. And so being able to reach out to them and tap into those already established sites. A part of the certificate is we have 2 courses. So the first one is Foundations of Integrated Behavioral Health, which is really just introduces direct practice of IBH, helps learners understand the role of a BHC, maybe engaging assessment, intervention planning, and implementing kind of what they're learning. The clinical skills, the second course is the clinical skills for the behavioral health consultant. This is where they really get to grow on that, build on that knowledge from the first class, and learn the evidence-based skills needed to be a BHC in an integrated behavioral health setting. Both of these courses have a specific components of working with Latinx populations, since that is the majority of our population down here in the Rio Grande Valley. Just a little background on clinic, kind of how we got the BHC trainees prepared for clinic. So we had a clinic there was ongoing clinic onboarding calls with the administrative team, just kind of getting everybody at the clinics ready, lots of meetings with leadership. and those on the ground at those clinics, and really orienting everybody to the role of primary care behavioral health and the behavioral health consultant. The faculty from the 4 disciplines, we met with each of them, did a 4-day intensive training led by myself and Dr. George. Faculty from each of the programs participated, and they learned about the primary care behavioral health model. There also was a preclinical boot camp that was required for all of the BHC trainees. This was really to orient them to their assigned clinics, what primary care behavioral health was, what is a BHC, what would their role look like. And we really focused on didactic lectures, reviewing common problems and interventions in primary care. There were several case discussions and then clinical simulations that we walked them through. Continuing training clinic readiness. So trainees for the first several weeks shadowed the clinic staff. So everybody from front desk, MAs, if there was somebody taking labs, the PCP, all the stations. So that way they really got a good understanding and foundation of what the clinic flow at their location looked like. They also attend weekly and bi-weekly 2-hour-long PCBH focused group supervisions. Weekly for the first month or so, and then it transitioned to bi-weekly 2-hour-long PCBH focus group supervision led by myself and Dr. George. The PCBH focus group supervision is again didactic lectures on topics. They're bringing up case discussions or patients as they're seeing. We're reviewing any clinic concerns and continuing to monitor progress. As the 2 sites that we were at this past year were 2 new sites, so wanting to just make sure that we were running things as smoothly as possible. The 2 sites that we were located at this year were AHEC sites. And so they were area health education clinics. And so these are in rural areas. And so it's not uncommon for there to only be 1 physician or provider assigned per day or half day. And so in the event that the physician or provider had to call off, the clinic would have had to been canceled. And so we did provide the students with home curriculum materials, which really just was PCBH focused and for PCBH focused education that helped continue to expand their role of the BHC and common interventions. And then we continue to offer IPE opportunities for them to continue to grow and build on that knowledge. And our goal is to offer at least 2 IPVs that we will coordinate for students yearly. And here are our references. Questions? I don't know if any questions came up during the chat.
I don't see any questions in the chat box, but if anybody does have questions, please feel free to unmute, or you can also put them in the chat box as well.
Oh, I think I see a raised hand. Stephen, you can unmute yourself.
Yes, when you're in the clinics, how do you coordinate? Because you go in with the physician, right, and meet the patient, and then you take the patient aside afterwards, right?
So I can speak to how it is at the clinic that I'm at the DHR Family Medicine Residency Clinic. So since it's a residency clinic, we have a precepting room that I'm sitting at that precepting room. I'm listening to students to the residents as they're precepting. And as things come up, I can get consults multiple ways. If I'm hearing things that I think I can be helpful for, I might kind of gently nudge or wait till after they're done precepting. Or sometimes residents have gotten really great about being like, hey, I want you to help me with this patient. Can you just listen while I'm precepting? And then we can kind of go from there. And so oftentimes they'll do what's called a warm handoff. They'll take me into the room. They'll introduce me, something very brief like, hi, this is my colleague Joanna. I often routinely include her in my care for patients who are struggling from X, and I wanted her to meet with you today. And so they might do their wrap up, and then they'll step out, and I'll actually stay in the room with where they were being seen, and I'll do my consult in that room. And our consults are usually around 25 minutes or so. And then that's kind of how that looks. In the event that they can't do a warm handoff, I would just kind of go and introduce myself, we have an intro that's like 2 minutes long or so, where I explain my services, who I am, and then do the consult.
And then while you're in the room after one of those warm handoffs, what happens if there's an issue with the next patient, but you're busy?
So that's kind of that's a great question. That's where that accessible piece comes in. So in a traditional specialty mental health clinic, we might have like a don't disturb in session sign. That's not the case here. So if you think of a clinic, we're constantly being interrupted, right? Maybe the MA has a question or a patient forgot something, and so they might go and grab the PCP. Same thing with me. So if there's another patient that comes up, they'll come in, and I'll kind of pause there with the patient. I might say something like, I want you to think about, and I'll kind of have them think about something. I'll step out, maybe introduce myself to the next patient, give them a heads up as to how many minutes it might be. And if they're able to hang out, they'll hang out and wait for me. If they're unable to, because they're crunched on time, we'll coordinate a time for them to come in for a scheduled visit just with me.
No, thank you.
Yeah, great questions. Other questions that you guys might have?
I don't see any other questions in the chat box. I did put the link if everybody could help us provide feedback, but do you have any other questions or even comments before we wrap it up here? Okay, well, with that, if you're okay with it, I'm going to email out also to everybody in attendance the link, but if you're okay, I'll include your email addresses as well in case people do have questions. But we want to thank everybody for joining, and thank you for presenting to us today.
Awesome. Thank you guys for having us. And absolutely, you can include our emails and reach out with any questions you guys may have.
Awesome. Thank you so much.
Thank you.
Bye, everybody. Thank you.